Sabrina?
Hi, welcome everyone to session 2 of the Learning Collaborative for Fostering a Healthcare Workforce Able to Address Current and Emerging Needs. Just to let you know, this session will be recorded and available for you to share with your team. If you have any technical issues, please alert Danielle through the chat box. You can communicate with her directly just by using the little drop down and alerting the organizer or the organizers and the panelists. And just to let you know, this session is part of the 2020 Social Determinants of Health Academy, which is structured around a set of 4 core competencies for addressing social determinants of health. We hope you'll join us for the next part of the series, which will cover strategies to reduce health disparities through community partnerships. So during the first workforce session, we gave a high-level overview describing the value of community health workers in supporting patients experiencing homelessness. And we also talked about strategies for training, recruiting, and retaining staff from the LGBTQI community. So today, we're going to build on that community health worker overview and talk about recruitment, retention, and training for CHWs. And then during the second half of the educational component, we'll talk about training staff to be culturally competent as they support members of the LGBTQI community. Following the educational content, we'll have 30 minutes scheduled for office hours And so, given the current COVID-19 crisis, we want to use some of that time to facilitate conversation about how community health workers are engaging in COVID-19 work, and then how we can be supporting LGBTQI health during COVID-19, so using that lens. So I hope you will stay and participate in that conversation. So this is just a quick reminder that we will have a brief session evaluation at the end of the educational component. Please fill that out for us. It helps us with quality improvement, but we also use that for reporting purposes. And then again, we hope that you'll stay for the 30 minutes of office hours and have an important conversation with us about how we're supporting our patients, particularly those who are really struggling with social determinants of health during this COVID-19 crisis. So I am Sabrina Edgington, the Director of Learning and Curriculum Design at the Association of Clinicians for the Underserved. That's me over there on the right, yep. And then we've got Colleen Velez from the Corporation for Supportive Housing. She'll be talking to us about community health workers. And then we have Kay Lambert, who's Program Manager at the Fenway Institute from the National LGBT Health Education Center. And so I'm going to go ahead and hand it over to Colleen. Who's going to get us started about talking about the community health workers.
Thanks, Sabrina. You can go to the next slide. Hi, everybody. If you are with us again from our session last week, you may remember my name is Colleen Velez. I am Associate Director for Federal Technical Assistance at the Corporation for Supportive Housing, or as many of us know as CSH. We provide technical assistance on a nationwide basis for HRSA through the Bureau of Primary Health Care, and also with HUD through the Homeless Office. And we primarily focus on SDOH and health and housing partnerships. So last time we were together, we were talking kind of on a high level around community health workers and how we think about incorporating those with lived experiences and what they can bring to our workforce, especially in addressing SDOH. And today we're just going to do a little bit of a deeper dive on kind of the processes around doing that, and how you as a health center may have to alter your processes as you've done them before to hire workforce, and even to hire CHWs to think about what you will need to do to be able to hire people with lived experience. So as you know, as standard, right, like the big things around this is recruitment and hire, right? So when we talk about this, we talk about it in a 2-stage process. The first is recruitment, which obviously involves candidate search, identification, screening, and assessment. And then the actual hiring process, which is the selection, the offer, the negotiation, and the onboarding. Next slide. So this slide really is focused obviously on recruitment portion of the two-stage and really talking about best practices when we're looking at recruiting for CHWs, for those with lived experiences, right? It's the way that we have to attract these candidates, have communications put together around attracting and marketing community health worker programs and getting those with lived experiences, and having the logistics that actually can get to the people that we're trying to recruit in. So communication is probably going to be looking different. You know, how you start to source and look at referrals is going to look a little different. And the logistics and how you are going to put that marketing materials out there or communications out there about the position is probably going to look different, right? So when you're looking at trying to recruit people with lived experiences, your sources and referrals are going to be coming from places that can draw and get those people, right? So you're looking at your clients, you're looking at your patients, you're looking at your community board. If you have partnerships with services partners within the community, like reaching out to case managers or housing providers or other health providers, you know, having your current staff do some scouting that maybe have a deeper connection to the community and understand the logistics on the ground in trying to hire those with lived experience, right? So it's just going to be a little bit different. You're not just going to do a normal post within your normal job boards to try to get somebody with lived experience. The communication, again, has to be different. There has to be different networking. If you have community health workers, obviously you want them to be involved in that. And if you already have, so they can talk about what the position is and doing that networking and trying to engage people who with lived experience who may be good to be part of your community health worker program. And then your logistics, again, like what your materials look like, how you're marketing that role, position descriptions that maybe use different language to describe what the community health worker position is in a way that looks more like what the day-to-day is, what the expectation is for that person, how the position works, like within the organization, things like that. Samples, you know, what scenarios, what kind of things that they would be going out and doing. Like the communication and the marketing for the position has to look different and be accessible for those with lived experience. Next slide. And then we have to look at kind of the stage 2 and try to understand what kind of the barriers or hurdles we might have as a health center in our hiring processes that would automatically just bump out people with lived experiences, right? So we're looking at how are we looking at resumes? What are things that are different for those with lived experience than somebody else who might be coming in and applying for a community health worker position, right? One, obviously, is life experience versus education. We know those with lived experience might not have the education that we normally post for a position like this, but they may have life experiences that equate to what we would want for education. And I think, you know, we talked a lot about this on the first one, and this is very equitable here, is that especially in trying to hire community health workers with lived experience, or when you understand the type of role that you want those positions to play, their life experience a lot of times is much more favorable for the work, right? So if you have your community health workers that are going out, doing outreach, engaging maybe those that are homeless, or engaging those that are have other SDOH issues, they have experience many times with addressing those issues, understanding those systems. So having somebody that's part of the community health worker program that has that lived expertise is, a lot of times way more valuable than what their education says on the piece of paper at the end of the day. You might have to look at things like, what kind of background checks do you normally do for hiring? Do you have to look at things that are like internships first or part-time first, and have periods of like experience on the job before you go to a full-time position for somebody? Things like that, looking at what is the structure of what your normal hiring practices are, and understanding that there most likely will need to be tweaks to those practices, because if you do not do that, there isn't a way for people with lived expertise to be able to become part of the community health worker program. You also have to think about this when we're talking about like doing the interview and presentation. You want to understand, again, what the role of the community health worker is going to be for your health center, or what you're doing in your programming. If it's the same type of work, or are you trying to expand to do different things? And then, obviously looking at quality and skill assessment, and having conversations with people with lived expertise when you are doing the interview process, relying a lot of times on scenarios and role plays, and asking about what they would do in that situation, things like that. Understanding what their organizational skills are, again, not so much of like what has your work history been, what has your education been, but really what has your life expertise been. And because we're trying to fit this type of role, or there's a certain role within our community health worker program that we're trying to fill, having questions and scenarios and role plays around that to see if the person has the basic skills, and understanding what kind of training or skill building that they may need to get to the level that you want them to be at. The other piece is kind of work culture. Again, and I think Kay will talk about this, and one of the things that we get asked a lot, and what we talk about a lot when we're talking about not only just community health worker programs, but bringing people in with lived expertise, is like the need for the adjustment of the work culture. Within your health center. You need to have clear expectations for people with lived expertise. Once you bring them on, you understand that there's going to be a lot of on-the-job training. We're not going to expect day one for people to walk in and be able, to do their job without support, without some on-the-job training. Working, if there are other mentors and peers there, having those people available to work with the new hires, and then supporting them in ways that maybe other workers that come from the field don't need to be supported. Like, do they need things like transportation? Are you making sure that they are getting a living wage and doing the same amount of hours as everybody else, right? Like getting those benefits to them when they walk in the door, and really being able to have the whole center and the work culture being around the support and the building the skills and the capacity of those with expertise for your community health program, which then also leads to having a work culture that allows time for that, right? We're all so busy, and it's an investment. It's not only an investment in money, because you're going to have to think about like doing postings differently and writing job descriptions differently, right? Like that's time in your HR day that normally isn't there. We're also talking about mentoring and mentorships, and do you have the time and the capacity built in to your current health center that allows people to make that space, to make that investment, to bring on and to have people with lived expertise as part of your programming, right? So there are shifts. There are hurdles. If you look at your health center today, there are probably hurdles in the way that you do normal hiring practices that you would need to think about and overcoming and working through, from posting to, interviewing to hiring through onboarding. And it is, again, an investment that you need to be making from kind of the top down to be able to bring in people that have lived expertise. Next slide. So one example that I wanted to provide for you today is HEAL. So there are many, well, you guys all know, if you're running community health worker programs, there are a lot of training curriculums around community health programs and all those types of things. So HEAL in Los Angeles, which is Healthcare Employment Advancement Ladder, has a peer specialist training curriculum that they do for community health workers, and that really focus on bringing in people with lived expertise, right? So it's focused towards not just the community health worker program, but those particularly with lived expertise. So, it's an 8-week employment prep program for those with expertise to gain skills, enabling them to seek and secure and retain their job as a peer specialist, right? So whether you have a peer specialist program, a community health worker program, either or, that they use this to try to train and prep people to do that work. The participants are recruited from the local service providers in the Los Angeles area, and the curriculum is kind of a combination of like self-esteem, self-care, knowledge, skill building, work readiness, best practices for peer engagement. I think we talked a little bit about this last time. People with lived expertise, a lot of them have trauma in their background, or they have other issues that maybe they are still, social determinants of health issues that they're still dealing with to this day, that are going to influence how they can work, their ability to work, and the skills that they need to be able to be a peer specialist, a community health worker with lived expertise. So the curriculum is a mix of all of it. It's not just work readiness. It's not just how do you be a good peer specialist, but it's dealing with all of it that talks about, their self-esteem, their self-care in this type of work, understanding the skills that they need to build, and then working on kind of the work readiness pieces of it, and understanding what kind of skills and building capacity for a peer specialist. They do work to build work experience through that curriculum, like through internships and things like that through the program. And it's also ongoing support for individuals once they're through that program, right? Like they then work to, they're setting their goals, they're working with them throughout, but then they work through getting them permanent employment, working with them then through retention and stability as well once they get into that position. They currently, we've been asking, CSE does a lot of work with them. They don't currently, I think they're currently working on kind of a public curriculum that they can, get out into the world, but they do not have that yet. But this is just the kind of programming that they have set up within their organization, and then within Los Angeles, the greater Los Angeles service area, looks to them to do this work and work with people with lived expertise to get them ready and into positions of peer specialists and community health workers with lived expertise. Next slide. So I am going to turn it over to Kay, but those are just kind of like the bigger, deeper strategies around kind of, again, soup to nuts of getting people with lived expertise into your community health worker program. So Kay?
Thanks so much, Colleen, and hi, everyone. So I'm going to be talking today about preparing your healthcare workforce to provide excellence in LGBTQIA+ or sexual and gender minority healthcare. And this is part 2 of this series, so we're going to be taking a deeper dive and looking at some more technical pieces of how to do this work. Next slide. So in building on what we were talking about before and also what Colleen was talking about earlier, so there's recruiting, there's retaining, and then there's the very important component about training staff. So in terms of training all staff in sexual and gender minority cultural responsiveness, there are some basics that pretty much everyone should be offered the opportunity to learn. And that's LGBTQIA plus concepts and common terms, sexual and gender minority health disparities, and what those mean for what you might see in terms of your patients coming in. Implicit bias, and we actually have a publication specifically about implicit bias for LGBTQ patients with specific case scenarios that's seen pictured on the left there. All of these publications are available for free on our website. It's also important to talk about sensitive and effective communication. I think one of the things that Colleen has been talking about, and when I think about building the workforce where everyone is competent to do this, one of the most important pieces is for everyone to know, okay, who is taking point on this? What is everyone's role? Where do we get to go from here? What is being done within the clinic? What's being done at the executive level? What's being done at the front desk level, and all of those pieces? And then also, what does sensitive and effective communication look like towards patients who are sexual and gender minorities? Talking about SOGI, which stands for Sexual Orientation and Gender Identity Data Collection, and then also confidentiality and privacy for sexual and gender minority patients. So all of these pieces should be available to all staff when you're building your workforce in this competency. Next slide. So we'll get into some details now. Next slide. When you're training all of your staff, or even if you're working with a particular group of staff, there are some things that you can expect when you're talking about training an entire workforce to be competent in providing sexual and gender minority healthcare. And one of that is anticipating and managing your expectations. So sexual and gender minority people have a history of experiencing stigma and discrimination in diverse settings. So that means that it's not unusual for these individuals to enter a healthcare setting feeling defensive, feeling frightened, feeling angry. So it shouldn't be a surprise that if, for example, a mistake happens, let's say that a front desk staff member uses the wrong pronoun with a transgender individual, that would result in the person becoming upset. And sometimes what I've seen when I've been working with our staff and our employees to try to train them in these competencies is the staff are very surprised at how upset and angry some of these patients become. And what's really happening there is the staff are seeing the result not just of that mistake in that moment, but of this history of discrimination and stigma. So in a lot of senses, I tell the workforce, don't personalize this reaction. It's likely actually not about you. It's important to apologize when the patient becomes upset, even if what you said was well-intentioned, and it can help diffuse a difficult situation and reestablish a constructive dialogue. So when I'm training the workforce, these are components that I make sure to build into my trainings, especially because without these ways of anticipating and managing expectations, a lot of the time staff feel like they can't do this work. Next slide. It's also important to avoid assumptions. So staff need to understand that they can't assume someone's gender identity or sexual orientation based on how that person looks or sounds. And here's just a really quick example of some of the techniques that I'll use when I'm training staff to avoid assuming gender identity and sexual orientation. So instead of saying something like, "How may I help you, sir?" say instead, "How may I help you?" You can be just as polite. Instead of saying, "He is here for the appointment," say, "The patient is here in the waiting room." So you're not using a gendered pronoun. Instead of saying, "Do you have a wife?" say an open-ended question. "Are you in a relationship?" Instead of "What are your mother and father's names?" ask, "What is your guardian's name?" Because people have all different ways of having family and building relationships. Next slide. We've got a lot of tools that go into much, much greater detail about how to navigate all of these different components. So some of the tools that we have are about, again, collecting that sexual orientation, gender identity information. And I would say that these are core competencies for a health center workforce. And these are available at the URL available on this slide. Next slide. We also have a series of pamphlets that are actually directed specifically at patients. So when I'm training new employees For example, a lot of the questions that I get are, well, what do we do if I ask for sexual orientation and gender identity information and the patient comes back to me and says, I have no idea why you're asking for this information, or I'm upset that you're asking for this information. And so what we did is we created these pamphlets that go into detail addressing the patient specifically, saying, this is why we ask these questions. This is why we ask these questions of every single patient. This is the information we're trying to get and understand, and this is why we're seeking that information. So we have those right now in 6 languages. We're currently translating them into 4 more languages, and also working on a Braille version of this pamphlet so that people can understand why we're asking these sorts of questions on the intake forms. Next slide. We've got a really robust set of tools for supporting gender diverse patients. I would recommend these 2 specifically when you're building up and then training your workforce. So one of them is specifically for frontline healthcare staff around affirming services for transgender and gender diverse people. One of the things I love about this publication is it has a cutout page in the back that you can remove and pin up. So when a front desk staff person is sitting there checking people in, they can have this cheat sheet pinned to their workspace that has, in very large lettering, some basic things to remember when you're working with the gender diverse community. So this is about not making an assumption. This is about asking for everyone's pronoun, asking for everyone's name used. If you get into a situation where, for example, the person has an insurance card that lists a different name than the name that is in their chart or the name that they gave you, how to ask respectfully to figure out what the name on the insurance is and why that might be different. And then we have a publication on creating an entire transgender health program. So thinking about building the workforce, I think can be as expansive as you want it to be. And we really encourage primary care providers, especially, to think of gender affirming care as primary care. And so inside your health center, we've got an entire publication that walks you through steps, everything from building up capacity, looking for providers who can do this work, all the way through, okay, now you have, insurance. What are you going to do to bill for insurance? All of those different pieces to create a transgender health program inside your health center. Next slide. And then I referred to this publication a lot last time we met, but last year we published this development toolkit for your workforce, which is on recruiting, training, and retaining LGBTQ proficient clinical providers. So I would strongly recommend checking out that toolkit and working through what it advises. Next slide. So I want to talk now about getting buy-in and executing on your strategy. So assuming that you have decided that you want to build your workforce, how do you actually go about that? One of the most important pieces is that the board and senior management are actively engaged in this process. So proactive efforts are essential to build an environment that's inclusive for sexual and gender minority people. This can't be something where you put up a rainbow flag and expect it to happen. And in order for that to be the case, engaged leadership has to happen from both the board and the senior management. Leadership can set a tone around sexual and gender minority inclusion as part of their commitment to a larger strategy for equitable care for all. And setting that tone at the highest levels of management makes it much, much easier for people who are clinical providers, people who are case managers, people who are frontline workers, people who are community outreach workers to say, okay, we've got endorsement, we've got backing to be able to do this work. Leadership also needs to provide the resources to create this change. So it's not enough for leadership to say, okay, we think it's important for sexual and gender minority people to feel welcome in our health center. They need to take action to actually make it so that people feel comfortable. That might look like a number of different things. Gender inclusive restrooms. It might look like participation in pride events or celebrations of other things that occur in the sexual orientation, gender identity type spaces. And it also looks like diversity and inclusion statements that are true for not just patients, but also for staff. It's also important to have staff champions who are involved in designing and implementing change. likely within a health center, there may be somebody who is already interested in doing this work, and it's important that that person be involved in designing the strategy for moving forward, and it's also important that that person be given the time to do so. Next slide. So talking about specifically non-discrimination policies for sexual and gender minority folks, the patient and the employee non-discrimination policies should include sexual orientation, gender identity, and gender expression. And this is very critical. The non-discrimination policy includes gender expression because, as we were talking about, there's no way to know for sure if somebody has a diverse sexual orientation or gender identity. And so the way that somebody chooses to express their gender is very much in the wheelhouse of a social and cultural construct, and no assumptions can be made based on that. And so those expressions that people choose should not present a barrier to their care. The policies, both for patients and employees, should be known by everyone in the organization, and there should be recourse when questions about discrimination are raised, and those recourses should be clearly laid out and accessible. So if there is a particular member of HR who deals with these specific kinds of complaints, everyone should know who that person is. There should be a way for folks to be held accountable. Also, if you are a federally qualified health center, non-discrimination policies are required by the Joint Commission. I've got the link down here on how to create these policies and also what is required to be adherent to these policies. I'm also happy to talk with folks about these policies and what they could look like, and you can feel free to email me for that. Next slide. Talking about accountability, this is something that I think is very important when thinking about building your workforce overall, because it has to do with how other employees interact with each other in an effort to create an inclusive environment for sexual and gender minority patients. So in my mind, the best possible outcome is that the environment of accountability is created by the workforce itself. And so it requires everyone to work together, and it requires that people aren't afraid to politely correct their colleagues if they make insensitive comments. So, for example, saying something like, those kinds of comments are hurtful to others and they don't create a respectful work environment, and then maybe explaining why that's the case. And if employees are given an opportunity to be presented with the idea of holding each other accountable and talking through this is something I do when I do trainings, is I say, okay, let's imagine that you all are going to hold each other accountable for your actions. Let's role play and go through what that might look like. And I find that it creates a much better result than having only a high level or a managerial level set of recourse for staff and employees, because I think it feels a lot better when your colleague can take you aside privately and say, hey, I overheard what you said. I feel like it didn't really feel very respectful or okay to me, and this is the reason why. And you talk through it with your colleague, and it's private. There's no sort of official reprimand or anything like that. And if people are given the opportunity to do that, a lot of the time they will, and those issues will be resolved by the workforce itself. It's important to have higher levels of recourse with upper management or supervisors, but it's also very important to give folks an opportunity to hold each other accountable. Next slide. So building on what Colleen was talking about, so for sexual and gender minority patients, it is also extremely important to have community outreach workers and to have people represented in your workforce who are also sexual and gender minority individuals. It can be hard because when you're doing an interview, unless somebody volunteers information about their sexual orientation or gender identity, it's not appropriate to ask about that information. So you may or may not know if the people on your workforce are sexual and gender minority individuals. So something that you can do is, if you don't have the ability to know for sure, and if somebody on your staff hasn't come forward and said, you know, I'm a member of this community and I really want to be engaged in this community outreach work, or if you don't have part of your health center that is about community outreach and is actively recruiting for people with these identities, you can ask patients if they would like to be on a patient advisory board where they can provide direct feedback. You can release community satisfaction surveys specifically about sexual orientation, gender identity, and how sexual and gender minorities are feeling inside your clinic. You can provide peer support and navigation services, so providing resources for the LGBTQIA+ community is really helpful. And you can also co-sponsor events and talks with community-based organizations. So we've got a picture here of the Boston Pride celebration. I think Fenway has been participating in Boston Pride since Fenway opened. So that's basically every single year almost that the celebration itself has been going on. And so thinking about how you can be involved and be visible as a community health center and demonstrate your support for these individuals. And then also, if you do have the ability to have a community outreach program, it's okay to post an ad that says, we're looking for a community outreach worker who has experience working with the LGBTQ community and who is comfortable going into queer spaces, sexual and gender minority spaces, going to clubs where these people are. Maybe you're looking for somebody who's going to be doing rapid HIV testing, or maybe you're looking for somebody who's going to be offering other services in terms of screenings, prevention, supportive services, that kind of thing. And it's okay to have an ad that says we're looking for a community outreach worker with this specific skill set. Next slide. So with that, I think we'll move into some questions before moving into the next part of the presentation.
Thank you, Kay. So this is Sabrina again, and I want to encourage everyone to use the chat box if they have any questions for Kay or Colleen on their presentations. And while we're waiting for questions to come in, I do want to let people know about our next session as part of the Social Determinants of Health Academy. We're going to be talking about reducing health disparities through community partnerships. It will actually be a different set of presenters who will be talking on that issue. That will be April 8th, where they'll provide the overview of the topic, and then they'll be providing a second session where they go deeper into the topic and provide more information to support implementation. We also will have a brief webinar evaluation that Danielle will provide for you. So if you will, please complete that. That will launch immediately following the session, and it will be emailed to you through WebEx. So we really appreciate if you complete that. And so I know some of you have been thinking about some of the questions that you might have around engaging community health workers and creating a safe place for people who are from the LGBTQ community. But I also want to open up discussion about how it is that we engage community health workers and how it is that we support our patients who identify as LGBTQ during this time of COVID-19. And so we have a set of questions that I want to start with. And I really encourage you guys to be using your chat to respond in terms of what are your experiences. You know, how would you answer some of these questions based on some of the work that you've been doing? And so we'll start with community health workers. And so I want to ask everyone, you know, what is it that you feel like CHWs can bring to this healthcare crisis? And when you respond, please be sure to send, I think you can send a chat to everyone. Danielle, can you confirm if that's the case, that folks can send a chat to everyone, or will it just go to organizers and panelists?
I believe it'll just go to the organizers, but I've sent in a question from Memo, if you can, which says, where can we find the employment training program curriculum?
And I think that question might be, is that the, I think that question might be for Colleen regarding the HEAL.
Yeah.
Okay.
Is it the HEAL or so? Right. That's what I was when I was speaking before. Right now, they don't have a public-facing curriculum. They're working on that. Obviously, as soon as we see anything come out, we will, we can get that towards to people. But the HEAL program doesn't currently have a public-facing curriculum for people to use, if that was the question for me.
Yeah, thank you, Colleen. So yeah, keep your questions coming. And while they're coming in, use the chat room to let us know what expertise do you feel like CHWs can bring to the COVID-19 crisis. So I'm going to read a response. So telehealth has become very helpful as a way to connect with patients during the pandemic. I have CHWs sharing their experience in accessing healthcare, and they say that this is going well. Oh, that's great to hear. And that they're able to then provide some education to help patients stay safe. I really appreciate hearing that. That was a question that I actually had, given that we are moving to telehealth, and a lot of outreach workers are very much accustomed to in-person outreach and that in-person connection. So I'm glad to hear that that's going well. What about others? What are some other ways that CHWs can be supporting? How are some other ways that CHWs can be supporting people experiencing homelessness or people living in poverty, or in other ways that they're engaging your patient population? So another response just came in. It says, we've been using CHWs to phone and check on the elderly and other vulnerable populations. That's great as well. Thank you. So keep your responses coming. And Colleen, I was wondering if you might want to talk on this as well.
Sure. And I would love to hear if, also as a kind of a follow-up of what people using telehealth and, using phone check-ins with community health workers, are they doing that from their homes? I'm assuming, or maybe. I would love to hear about like how that logistically is working. If they have to come into the health, I would assume maybe with telehealth, they would have to come to the health centers to be able to do that. But if you have people just phone checking, are they able to stay in their own homes and do that work? Because that's a great asset to your health center as well. Again, I think that's part of it, right? Like, so we have, if we're talking with people with lived expertise, they can be very valuable in this time of understanding and navigating the other care systems, because they have dealt with them before, and making sure that people are still being connected to primary care or getting the health care they need if they are if they are like unsheltered or they are in shelter situations, and in understanding how things shift in a health crisis for things like transportation, getting food and food banks and things like that, and making sure that if you are a health center that deals with these special and vulnerable populations, again, if you have a telehealth way or a phone check way, they are able to provide that information to that patient population a lot of times, right? So they understand or and have a pulse on how things change in these other care systems that then can be a resource for your patient population. I think too, you still have to, deal with, again, people with lived expertise, what triggers that they may be getting from a current pandemic or a current health crisis, if they have been through one themselves, or if they've had some type of health crisis when they were in a very unstable situation. This is all maybe triggering for them. So being able to have that support for them, especially if they are currently engaging in the work. They may need some time, right? They just may need to not be involved because it's too traumatic for them to go and work with people who, if they're a person who was homeless once prior, working with people who are homeless during a health crisis just may be too triggering and too much for them, and they may need just to be able to say, I just need to take time. And so you have to be able to build in that support that way. So, I mean, there's a lot of things that community health workers can bring in a crisis. But again, if you're thinking about people and having workers with lived expertise, depending on their background and what they've made experience, this could actually be a very, very difficult time for them, and being able to have that understanding and the culture behind your health center for them to feel comfortable enough to say, I can't do this right now. This is too hard for me. I have to be able to take care of myself within a time like this, So just thinking about those aspects of it.
Great, thank you, Colleen. And we also received a couple of responses about your question regarding how they're doing telehealth, whether or not it's from the office or whether or not it's from their home. And so one response is saying, we're calling from our homes. Our organizations provided all of the CHWs with a cell phone, and we use a shared spreadsheet to help identify need. That's great.
Oh, that's great.
And then, and another participant said, many of our patients use their smartphone. Most of the staff are still in the office, but we're limiting the office services. It may come to the point where staff are working from home and are provided appropriate equipment to do so. So that's a really good point in terms of, if we are asking CHWs to work from home, how are we equipping them to do that? Do they have internet access from their homes? Internet can be quite expensive. Do their phones have the capacity to not only make calls, but to check internet? Is that how they're checking their email? So looking at all of that. We received another comment that says, we're also using our local Meals on Wheels to check in on people. That's a really interesting idea as well, and one I've not heard. Another participant said a lot of peer support is via phone calls if video conferencing is not available. That's great. And then another comment said, I did have a staff member state that they were experiencing increased anxiety. Okay. They had staff members state that they were experiencing increased anxiety, and they were supported, and so they make sure that they have open availability for those staff to be able to support them. Great. And then another comment came in that said, immigrants need a lot of support in times of crisis like this, because their daily stress for their condition is also added to how they can access benefits. That's a great point. And, a lot of community health workers are working with immigrant populations or individuals who don't speak English as fluently as some others. And so that's also a great comment. I'd love to hear from others who are using CHWs to support immigrant populations. So keep using that chat box. Have your health centers been working with your immigrant populations around COVID-19? And if so, how are your community health workers supporting this work? So one person said community partnerships have been helpful. We have health plans working with our staff and engagement efforts. It's taken a lot of thought and creativity. Oh, that's great to be able to work with the different partnerships, working with different organizations to bring healthcare services and provide information about COVID-19 and how that's being treated to those different organizations that different members of your communities work with and trust. Another comment came in. It says, unfortunately, I work in New York City and we're at 100% non-essential working from home. And the agency was really not able to have time to go time to go telehealth, phone checking, and enough time. And our staff have been trying to email, call as best as possible with what information we have, but with limited resources, especially hard with the homeless population here in New York City. I can imagine New York being especially hard hit right now and under orders to stay at home. And so this can create a lot of challenges, especially if the health center wasn't prepared to do telehealth in advance. And so that's another question that I have. How many of your health centers are considering your community health workers as essential versus non-essential staff? So while you're answering that, I'll chime in with another comment that we received. CHWs are providing our members with food resources now that people are out of work and kids are home from school. That's a really great use for community health workers, to provide a needed resource and also just to check in to see how they're doing. And I'm wondering if you're using your community health workers to also provide some additional information about COVID-19 when they do bring in food resources and check in on your patients, just because there's so much bad information going around.
Mm-hmm.
So we received another comment. For our children's program, we're partnering with local schools who are providing equipment for families without it, and this has helped to provide support as well. And they have, with consent of parents and guardians, completed activity groups such as art and reading. So that's wonderful. I know in a lot of places, the schools are handling the COVID-19 crisis a lot differently. For example, in some communities, they are going digital for digital learning. They're offering that opportunity, but then in other communities, they're really considering equity issues and the fact that a lot of the low-income students don't have internet access and not offering digital opportunities. So it's great that there are some activities that you're providing to parents and children. And so regarding my previous question about whether or not you're considering community health workers essential or non-essential employees during this COVID-19 crisis, one person responded back that they are considering their community health workers as essential. And then another response is, yes, they are essential and they're helping a lot with sharing valid resources and reducing anxiety. Great, thank you. Does anybody on the line have any additional questions for each other? So it could be for our panelists or it could be for one another in terms of how community health workers are engaging in our COVID-19 response. I'd love to give you that opportunity to ask questions and share any additional information that you think might be helpful before we move on to talking about the COVID-19 response in support of the LGBTQI community. So I'll give you a few seconds to type in any questions or comments that you might have. All right, and I really appreciate the dialogue that's happened so far. It's been really interesting to hear how community health workers have engaged in this work. Feel free to continue to add to that chat. But for right now, I want to go on to talk about some of the questions and considerations for sexual and gender minorities. And, one of the questions that I want to ask is, what are some of the considerations for sexual and gender minority college students who are now being asked to return home during this COVID-19 crisis? Feel free to add to your chat. And while you're responding to that, I want to read out another response that we received. And it said, speaking for New York City and my agency, anyone who is not providing food services, bag food, or agency, everyone was told to stay home. So case management, prevention services, mental health services, etc., are all non-essential per Governor Cuomo. I had the hardest time saying his last name, so apologies, which is 90% of the agency. Wow, that's interesting. And, coming from New York City, which is so hard hit, I can imagine there are a lot of, risks or a lot of prevention factors and mitigation factors that have really been part of the discussions that led to that decision. So thank you for sharing that. And we're all really watching New York because, we don't know where the rest of our country is going to be. And so, seeing how this all plays out is really important, and doing what we can to support everyone in cities like New York. So thank you for sharing that. So while we're thinking about some of the considerations for sexual and gender minority college students who are asked to go home during the crisis, I want to see if, Kay, if you'd be willing to talk on this a little bit.
Absolutely. And I think that the questions that I'm asking here specifically about COVID-19 considerations for sexual and gender minority folks fit in very neatly with the questions we're asking about how can you mobilize and utilize the community health workers that you have. One of the things that we've done is we actually have, through our community outreach and engagement arm, which is called AIDS Action, we have some really savvy people who have a very large social media presence. And so this certainly doesn't solve the problem for folks who aren't able to access the internet, but for people who are able to access the internet, we have ongoing Instagram and Snapchat, and I am certain there are platforms that I don't know the names of that they are doing things on. And so our community outreach workers are actively on those websites, and they're working from home, as with the person from New York City. Almost everyone at Fenway Health who is not a clinician has been told to work from home, but we're having our community outreach workers stay on the clock and continue to work. And one of the things they're doing is responding to people in real time using those social media outlets that we built. Something that I think is important to think about for college students who are being asked to return home is that for a lot of these students who are sexual and gender minorities, they may be returning to a home that is unsafe or unsupportive. They may have left for college with the idea that they would never go back home because they may have come from a space that wasn't affirming of their sexual orientation or gender identity. And for some of these students, they may have started living as their authentic selves once they got to college. And so the idea of returning home could be very daunting. And yet for other students, they may actually have been kicked out of their home prior to going to college and may not have a home to return to. I think that for a lot of colleges, they're sort of giving out this blanket statement like, okay, everyone go home. And that's not something that everyone has access to. And I think this is where it really intersects with Colleen's comments about the challenges that people who are experiencing homelessness are facing, and how can we mobilize community outreach workers and the workforce generally to try to assist folks in this particular situation. I think somebody might have had a question that came up or a comment that came up.
Yeah, and really the comment just echoes what you're saying. They're saying that some LGBTQ students come out after they've left for college to avoid any conflict with parents, and being unsure about approval, coming home unexpectedly may create conflict for the student on how they express themselves at home.
Absolutely. One of the things that we've been talking, especially with our community outreach workers about, is what are alternatives for these students? Are these folks who we can help them to figure out short-term housing solutions? I know in a lot of major cities, and certainly in Boston, there's an organization on Facebook for most major cities called Queer Exchange, and then insert the name of the city. So there's Queer Exchange Boston, Queer Exchange New York, Queer Exchange Philadelphia. And on those exchanges, we're seeing a lot of people posting, I have a room open if somebody needs a place that's safe, or I need a room, I have nowhere to go, I'm not welcome at home. And so I think that looking at those resources, and again, if somebody doesn't have access to the internet and is able to come into the clinic, one of the things that our providers have started doing is they will use the internet for a person. If someone comes in and says, you know, I don't have internet access right now and I'm kind of between a rock and a hard place, the provider will say, okay, I can take a moment and I can look some stuff up and print things out for you so that you can figure out what to do next.
Right, thank you. And you know, that brings up that intersection between homelessness and LGBTQ, because we know that, I think, correct me if I'm wrong, 40% of people experiencing homelessness identify as LGBTQIA. Is that correct?
Yes, and it's closer to 80% for youth. Yeah, but
wow.
40% of general homeless population.
And so, you know, I imagine that our shelters have a high number of people experiencing, excuse me, let me just set this down. Our shelters have a lot of people who might be considered sexual and gender minorities. And so that makes me question, and this is a question, Colleen, for you. Do you know how many of the peer specialists and CHW programs include a training component around LGBTQ health?
You know, that is an interesting question.
Common case.
Yeah, I don't know. So like I said, the HEAL program that I talked about is one that's, you know, particular for those with lived expertise. I haven't seen anything out there like that in particular when we're talking about, and again, most of my frame of reference is bringing in people that have been homeless, that talk about, you know, gender minority or, you know, LGBTQ in particular around that. But we know the intersection is there. I mean, a lot of the, you know, bringing people in who are homeless at our peers, it's a lot more of conversation around, you know, trauma-informed care, because we know that people are coming, you know, from a place of trauma most times that have been, you know, homeless. But I haven't seen anything in particular in curriculums or things like that for peer specialists for homeless, right? Bringing people in with lived expertise that specifically addresses that aspect of it.
Okay, yeah, and you know, if anybody on the webinar wants to comment and let us know if you have either participated in a training like that, if you're a community health worker, or if your organization has integrated that into its community health worker onboarding and training process, that'd be interesting to learn about as well. And so while you're typing in your responses, let's think about this next bullet. What fears might someone who is LGBTQIA+ have about their healthcare in the context of COVID-19? And I want to ask that of our attendees, our participants. What are some of the fears that they might have in the context of COVID-19? But also, Kay, maybe you can speak on this while people are responding.
Absolutely. And also just to make a brief comment on the previous discussion point, one of the things that we have done is found community members who have both the lived experience of being homeless and have the lived experience of being a sexual or gender minority. And at least in Boston, we've had pretty good luck connecting those individuals directly with organizations. Like there's a center that operates a day service that provides educational resources, internet, meals for people experiencing homelessness, and then connects them with overnight shelters in Boston. And we've connected a number of community folks with that organization specifically, and then the organization themselves will hire that person, usually on a per diem or an hourly basis, to provide trainings or education to residents and people who are engaging with that program. And we've seen some really good success there. So that's one strategy to think about. In terms of fears that sexual and gender minority folks might have about their healthcare in the context of COVID, I think it's important to remember that sexual and gender minority people are disproportionately discriminated against in healthcare generally, even when there is not a pandemic. And so if somebody is thinking to themselves that they may need to go to the emergency room has historically been a very unsafe place for sexual and gender minority individuals. And so people may be very afraid about whether or not they can get the health care they need if they do become ill. Another fear that people may have is that their medically necessary care may not be seen to because people are focusing pretty myopically on COVID. So for example, people who are transgender may be taking hormone therapy, and it's really important that that hormone therapy, that gender affirming care, is medically necessary and needs to continue regardless of what's going on with COVID. And one of the things that I often say is, if as a health center people are still being taken care of around their diabetes and their hypertension and, any number of other medical situations where they have medically necessary care, the same is true for sexual and gender minority patients. So people need to be able to continue to have access to their hormones. People need to continue to be able to have access to PrEP and PEP, pre-exposure prophylaxis and post-exposure prophylaxis for HIV prevention, and that those things can't just stop. But I think a lot of sexual and gender minority folks have expressed to me that they are afraid that they won't be able to get the medication that they need because of COVID-19.
Wow. And so what is the general, and I don't know that you can answer this, and maybe you can, and maybe there are others on the line that can answer this, but what advice are you giving to people who need to get access to their medication, to their hormones, but are scared to go to the hospital or the health care setting because they're being told to stay home, because people are being told that the priority is for people who are showing symptoms of COVID-19? Do you know what the response is? Absolutely.
So I think it evolves day to day. One of the things that I know our providers are doing is, a lot of our providers are moving to telemedicine unless it's absolutely necessary that somebody come in. And so our providers are willing to see pretty much anyone in those telemedicine visits. And so if somebody is afraid that they're going to not be put at the top of the priority list in terms of getting a prior authorization for a refill, or the person's hormones are completely stopped, or maybe the person does return home from college, for example, and their prescription doesn't transfer with them, something like that, our providers are just saying, okay, talk to me a little bit about your experience, what your dosage is, what medications you're taking, and then they're sending in the refills and really trying to reduce the barriers to getting people into care. Ordinarily, under ordinary circumstances, with a new patient, we would have them come in and we'd get to know them and we'd talk about what their regimen was, and ideally they would have enough medication to take them through getting some blood labs done, for example, something like that. And we're trying to pull down some of those barriers because we don't want people coming unnecessarily into the healthcare setting, and we also want to acknowledge that some people may have had their medication regimens kind of ripped out from under them. So that's certainly something that we're doing. Another piece is, again, engaging those community health workers, those community outreach workers. If those workers are familiar with resources for sexual and gender minority folks, they may be able to tell people, this is an LGBT-friendly healthcare provider in your area, and this person may be able to continue your medication, or even if you're not physically going anywhere, you might have to switch your doctor to somebody who's willing to prioritize your healthcare in that way.
Great. And I really like having community health workers be very explicit in saying that, because I think that does create a more welcoming environment. So I appreciate that. Thank you. And we do have a couple more comments coming in. So One participant said that their organization has planned for training their staff in order to offer training, so train the trainer to offer community stakeholders who work with LGBTQ youth. That's great. And then another participant said that they were thinking that a possible fear could be, how can I access services if most places are shut down or have limited staff, and a fear of how long the timeline of that will be. It's a very valid fear. And then another participant said, we actually get a lot of individuals who access STI, HIV rapid screening in South Bronx at no cost. And another fear could be going to a place that requires insurance, or yes, you could go to the hospital because you're nervous of HIV exposure. What will the experience be like, and will I get adequate information about HIV, PrEP, with everything now focused on COVID-19? So really echoing some of the things that you just said, will their needs continue to be met at a time when people are really focusing in specifically on COVID-19? Great, thank you for your comments, everyone. Keep them coming. And I want to move on to the next question while folks are responding. What can your organization do to help support the needs of LGBTQIA patients during the pandemic? So we've heard Kay mention a couple of things, including having CHWs check in on people, being explicit about, we are still available through telemedicine to refill your prescriptions. What are some other things that an organization can do to help the needs of LGBTQIA+ patients during this pandemic? Go ahead and use the chat box just to let us know either things that your organization is doing or things that you think might be good for organizations to do. And you can also use this time, just if you have any other lingering thoughts or questions, or just, issues at your organization that you're contending with right now that you want to work out. We're happy to kind of talk through things. This is office hours, so it's a really good time for us to provide technical assistance. So if you have any challenges you want to work through, feel free to add those as well. And while you're doing that, I'm going to go back to the slide with our contact information, because all of us are here and available for you. Obviously, Kay has a lot of expertise in building staff competency around LGBTQ health and culture. Colleen can talk and support your organization on community health worker training, particularly around supporting those patients who are experiencing homelessness. I can provide you with tools and resources just around general health center workforce needs, such as recruitment, retention, a lot of the things that health centers need in place in order to maintain a skilled and stable workforce. So we're all available to you. Our emails are on the screen right now, and we welcome you to reach out to us at any time that you need any support in any of these areas. So I am not seeing any other questions coming in. So you will have access to these slides. I'm going to get back to our last slide. Apologize for that. You will have access to these slides. They will be sent out. And this is a link to the Social Determinants of Health Academy, where you can sign up for the other sessions. So you do have to sign up for them individually. So please check them out. And we really appreciate you participating in the session. Thank you to Kate and Colleen for your thoughtful presentations, and we hope you all stay safe and healthy, and please be in touch with us if you need us. Thank you so much, everyone.
Thank you.
Thanks so much, Sabrina.